Good afternoon, colleagues. This is meeting number 90 of the Standing Committee on Public Accounts, Thursday, March 22nd, 2018. Today we are here in consideration of Report 4, Oral Health Programs for First Nation and Inuit Health Canada of the Fall 2017 reports of the Auditor General of Canada. I would remind all those guests as well as members of our committee and those in the audience today that we are televised, and so I would encourage all of you to turn your phones onto silent or vibrate or whatever setting you want it on, just so it doesn't interrupt. Sometimes when it's seated or the phone is beside the microphone, it throws everything off. So if you would please do that. I also welcome our witnesses today, and we have the Auditor General of Canada, Mr. Michael Ferguson, welcome back. As well, from the Auditor General's office, Joanne Schwartz, Principal, welcome to you. And from the Department of Indian Affairs and Northern Development, Jean-François Tremblay, Deputy Minister, and Sony Perron, Associate Deputy Minister. David Peckham, Chief Audit and Evaluation Executive, Audit and Evaluation Sector, as well as Marc Plante, the Manager, Dental Policy, First Nations and Inuit Health Branch. Colleagues, I would like to point out that when this audit was undertaken by the Office of the Auditor General, the authority and responsibility of First Nation and Inuit oral health programs fell under the purview of the First Nation and Inuit Health Branch within Health Canada. Due to an order in Council dated November 30th, 2017, it is now under the purview of the Department of Indigenous Services Canada, and thus the reason why we have officials from the Department of Indian and Northern Development as opposed to Health Canada. So we welcome our guests today, and I would open the floor and turn it to Mr. Ferguson, our Auditor General. Welcome.
Thank you. Monsieur le Président, je vous remercie de nous donner l'occasion.
Chair, thank you for this opportunity to present the results of our audit on oral health programs for First Nations and Inuit. In our audit of Health Canada's oral health programs, we focused on whether the department knew if its two programs, the Non-Insured Health Benefits Program and the Children's Oral Health Initiative, had a positive effect on the oral health of Inuit and First Nations people. These programs are important because they provide access to a range of medically necessary dental services. We concluded that while Health Canada provided access to these important services, it could not demonstrate how much the services contributed to their objective of maintaining and improving the overall oral health of Inuit and First Nations people. Even though the department knew that the oral health of these populations was significantly worse than those of other Canadians, it did not focus on closing the gap. Moreover, the department had not finalized a strategic approach to help improve the poor oral health outcomes in the populations it served.
That its $5 million Children's Oral Health Initiative, which is focused on prevention, improved the oral health of some First Nations and Inuit children. However, the department's data showed that fewer children were enrolled and fewer services were provided under the initiative than in previous years. Health Canada didn't know why this was the case, making it difficult to address the situation. We also found that there were administrative weaknesses in the department's management of its non-insured health benefits program. The department's service standards for making decisions on pre-approvals and complex appeals weren't clear. Also, Health Canada didn't always inform its clients and service providers promptly about some of the changes it made to the services it paid for. This matters because delayed or unclear communication about what services are available can affect clients' access to the oral health services they need. We also found that in the two regions we examined, Health Canada was slow to take action to address human resource challenges. If unaddressed, these challenges could eventually affect service delivery. We made 6 recommendations, including that Health Canada should finalize and implement a strategic approach to improve the oral health of Inuit and First Nations people, an effort it began in 2010. We also recommended that it should develop a concrete plan to determine how much of a difference its programs are making to the oral health of Inuit and First Nations people. Santé Canada a accepté nos recommandations.
Health Canada agreed with our recommendations and committed to take corrective action. Now that these oral health programs are the responsibility of Indigenous Services Canada, we understand that it intends to fulfill the commitment made by Health Canada.
My opening remarks would be pleased to answer any questions the committee may have. Thank you.
Thank you very much, Mr. Ferguson, and we'll now turn to Mr. Tremblay, and we look forward to your comments.
J'aimerais d'abord remercier.
First, I would like to thank you, Committee Chair, and the rest of the members of the Public Accounts Committee for the invitation to speak here today. I'd also like to acknowledge at the outset that we are meeting on the traditional territory of the Algonquin Nation. I'm accompanied by my colleagues, Sonia Perron, Associate Deputy Minister, Marc Plante, Dental Policy Manager, and David Peckham, Chief Audit and Evaluation Executive. I wish to assure committee members that officials from Indigenous Services Canada welcome the recommendations of the Auditor General of Canada's Oral Health Report. And we're fully committed to their implementation with First Nations and Inuit partners. Dental services provided to First Nations and Inuit cover a lot of people. Last year, more than 300,000 people received dental benefit services through the Non-Insured Health Benefits Program, while the Children's Oral Health Initiative provided oral health services to 237 First Nations and Inuit communities. However, it's important to note that these numbers do not include First Nations served by the First Nations Health Authority in British Columbia, which began to administer all federally funded First Nations health programs in 2013. In all other provinces and territories, Indigenous Services Canada relies on an interdisciplinary team of oral health professionals to both advise and manage the suite of oral health programs and services.
Direct clinical preventative oral health services for children, including screening, application of fluoride varnish to prevent tooth decay, placement of sealants on teeth to help prevent tooth decay, stabilization therapy to stop the progressions of cavities, and the provisions of oral health information sessions at the community level. In 2016, through the Children's Oral Health Initiatives, 16,000 children received dental screening, and 10,677 children received at least 2 fluoride treatment applications. According to the recent published national report of the First Nation Regional Health Authority survey, access to oral health care for First Nations children aged 0 to 11 living on reserve and in northern communities has increased since the RHS Phase 1 from 69.1 to 71.4 in 2015-16. Based on the strength and existing programs, new funding was received in budget 2017 to support the increased utilization of non-insured health benefit and to invest $45.5 million over 5 years to expand the Children's Oral Health Initiatives. Following regional engagements with First Nation and Inuit partners, the Department has developed detailed implementation plans for these investments, which will result in greater First Nations and Inuit access to oral health and at the community level. Comme l'a recommandé le vérificateur général, le ministère a entrepris des...
As recommended by the Auditor General, the Department is also completing a comprehensive plan to improve measurement of the impacts of First Nation, including data collection, analysis, and reporting. This plan will help ensure that data collected in the course of the delivery of service under the Children's Oral Health Initiative and dental therapy programs are accurate and rich enough to contribute to the department's overall management and quality assurance of these services.
Also available, the department is working with the Public Health Agencies of Canada's Office of the Chief Dental Officer, Statistic Canada, and First Nation and Inuit partners to explore the feasibility of conducting new First Nations and Inuit oral health surveys. This could dovetail with an oral health component of the Canadian Health Measures Survey cycle in 2022 and 2023. The department has also sought the advice of non-insured health benefit program oral health advisory committees on ways to improve its oral health data collection and analysis. The committee is composed of highly qualified, independent oral health professionals and academic specialists. The committee provides the departments with impartial expert advice on a variety of topics, including current and evolving best practices, evidence-based oral health prevention and treatment, non-insured health benefits oral health policy, clinical technologies and procedures. We have recently received feedback from the committee, which we are incorporating into our oral health data plan. In addition, there's a research funded by the Canadian Institutes of Health Research that aims to evaluate the impact of children's oral health initiatives in First Nations and Inuit communities across the country. The department intends to review the findings of this research in order to identify further service improvement. Regarding the integrated oral health approach, le vérificateur général recommande que le ministère...
Auditor General recommends that the department finalize and implement a more strategic approach to First Nations and Inuit oral health and actively monitor its implementation. The approach would be accompanied by a detailed action plan to be delivered by June 2018 in an effort to reduce the oral health disparities experienced by First Nations and Inuit. The department is leveraging the opportunity under this new integrated oral health approach to set evidence-based targets in discussions with First Nations and Inuit partners that will measure progress in reducing these disparities. Getting these targets will require the department to better mine the data captured across its programs to create a more robust and holistic profile of First Nations and Inuit oral health needs and outcomes.
Culture, context, and the social determinants of health into consideration. The integrated oral health approach is in its final stages and development and will be presented for approval in June 2018 to the First Nations and Inuit Health Branch Senior Management Committee. Members of the committee include the Assembly of First Nation and Inuit Tapirat Kanatami. Service standards, decision-making, and communication. The Auditor General also calls on the department to better document and how decisions are made on changes to the coverage of health benefits for the non-insured health benefit programs. In particular, the Auditor General specifies the need to ensure that both service providers and clients are advised quickly of these changes. We accept this recommendation. Un examen du diagramme du processus décisionnel.
Examining a diagram of this process has allowed us to strengthen our process for policies and to improve the management of the program. The Auditor General has also recommended that the department clarify the service that are subject to prior approval and also improve data entry in the appeals database so to make sure the information is correct and reliable. We accept this recommendation.
Their development and will be finalized in April 2018. Information from clients and providers will be provided in a more clear and timely manner. The department's further revised the appeal sections on its website, including clearly stated service standards for appeals. Quality insurance processes are currently being developed and implemented to ensure improved data entry and appeals database. The department is also in the process of revising its service standard for dental predeterminations. Responding to human resources challenges now, lastly, the Auditor General recommends that the Department implement strategies to ensure adequate human resources capacity to deliver First Nation and Inuit oral health programs over the long term. We, of course, accept this recommendation, and to respond to it, regional service delivery plans are underway. These include regional specific strategies to identify and address human resources needs. In addition, the Department is supporting the Canadian Dental Hygienists Association to advance their work on curriculum development for an expanded scope of the oral health practitioners. The Department encouraged all the non-insured health benefit providers to enroll with its automated claim processing system, allowing claims to be processed in real time and payments to be deposited. This greatly simplifies administration and timeliness of payments to providers. En terminant, le ministère s'est engagé.
In closing, the Department is committed to continuing to expand access to oral health services that contribute to the overall well-being of First Nations and Inuit. As the AG's review makes clear, we recognize that there is room for further improvement, and we are taking concrete steps to improve service delivery.
Our Indigenous partners to support better access to effective, sustainable, culturally appropriated health services, and to expand their roles in the design, management, and delivery of oral health services. We will be pleased to answer questions. Thank you.
Monsieur Tremblay, merci.
Mr. Tremblay, Mr. Massé, you have 7 minutes. Thank you, Chair. Thank you, witnesses, for being here today in order to answer our questions. And thank you also to the Auditor General for your excellent report. My first question, Mr. Tremblay, you mentioned in your opening remarks that there's structure for children and family is now under the purview of Indigenous Services Canada in order to better meet the needs of First Nations and Indigenous peoples throughout Canada. Can you explain this to exactly why, how we're going to be able to help provide services for further First Nations and Indigenous peoples in Canada? For us, what's important is our ability to work on social health determinants. When you work in the health field in terms of tuberculosis, you have to look at housing as well and building of houses. In terms of oral health, you have to look at other determinants as well, such as food safety. So there are a lot of different factors that come into play when you try to treat someone's health.
Is offering us a capacity, and you take, for example, one example that is actually quite easy to understand is mental health. Mental health touches to many areas in health, not only one place. So you've got different ways of approaching it, and working with child family services, for example, on one side, what you do on income assistance, what you do on health, what you do in other elements, on other areas, it gives you a chance to have an approach that is more holistic and develop an approach that over time will better respond to the needs of the community, and also on the way they want to shape their programs and the way they want to respond to the challenges that they're facing. So for us, it's actually a very good opportunity. It does also, in many aspects, reiterate the points made by the Auditor General about the needs of better data. Because if you want to do that, you will need to have better information about what exactly impact what, and how do you have an impact on those information, and how can you improve success, and how can you improve the situations over time. And that's for us a challenge that, of course, we will look forward to develop and to address in partnership with our partners over the next few years.
Merci. Dans son rapport,
Thank you. In his report, on page 7 in French, in section 4.28, the Auditor General mentions an important point. He says in this paragraph that we noted that the department wrote draft strategies for oral health in 2010 and 2015 without implementing them. The department committed in 2015 in its report to implement an action plan and a strategy with regard to oral health. And there were regional plans for oral health services, and they also continued to discuss a approach, but in 2016 the department gave a service provider the mandate to establish a plan. And I wanted to hear what you have to say about that. At the end of the audit, the department did not finalize its strategic approach, it says. So could you explain the reasons why, at the moment of this report, why this strategy had not yet been developed and implemented? I know that you have very qualified public servants, and as you are also qualified, and in your department, I know you're preparing. You prepared a lot and did a lot of work for this appearance today. So could you explain at this time why there is still no concrete strategy in place to meet the needs of these people? We developed an approach, but it was much more of a regional one. We work a lot on the regional level because health systems, as you know, are a provincial jurisdiction, and the rules are different from one region to another. So there was some work that was done.
Have the, I would say, the means of his ambitions at the time. With the funding that we received in budget 2017, we decided it was an opportunity to step up, and with the report from the Auditor General helping, we're now moving towards what is more a national strategy, where we would exchange information from regions to regions, looking at the trends, looking at where we're going, what we think are the needs, and also exchanging about best practices from one place to another. For example, on human resources, the services are not necessarily shaped the same way, especially on the co-high side, on the oral health initiatives. They're not necessarily shaped the same way from one province or from one region to another region. So I think the departments, there was intention to develop that, and I will leave my colleagues to say more about that. But I think the first thing was to address the regional aspect, but there was not necessarily the second level, if you want, which is more a real national strategy. I think with this report and with the engagement that we're taking now, we're basically putting the system at a maturity level that we would like to have, that I think we need to have for the future.
À quand pourrait-on s'attendre d'avoir cette...
When should this national strategy be in place so that you can implement it quickly? Because Indigenous communities, and I have two in my riding, are expecting our government to really implement it concretely. So a national strategy is important. It's an important part of this approach. So what's your game plan? What's your timeline for developing this national strategy? So I'll ask my colleague to talk about the next stages and the timeline. In terms of oral health, we're at the senior management stage right now. So we're trying to find... We have separate programs in terms of children's oral health and NIHB. So we're going to establish priorities for these different branches. So everything will be going in the same direction in terms of oral health then. So objectives will also be established, and we'll have clear targets. So that's we'll have a game plan for the next 10 years.
Now, Monsieur Deltel.
Merci beaucoup, Monsieur.
Thank you very much, Chair. Ladies and gentlemen, welcome to the Parliament. Mr. Ferguson, once again, I'm happy to see you, and congratulations for the quality of your French and for being so bilingual. My question is now for people from the Department of Indigenous Affairs. I'm always very proud to say that I represent an Indigenous community, the Wendat community near Quebec, Wendat. It's in the heart of my riding. So I've been neighbors to them for my entire life. And the reason I'm talking about this, as everyone knows this in Canada, there are some semi-urban and urban communities and others that are less dense. You also know that when you need a dentist and it can be urgent, everyone's had a toothache, and on a Sunday or a Saturday, it's hard to find a dentist, and it's happened to me before. Nevertheless, I'd like to know, when we talk about 300 Indigenous people and 37 communities, and perhaps my question is addressed to people from the department, is there a clear difference between Indigenous people who live in more urban centers or those who live elsewhere in terms of dental health? I'll ask my colleagues to answer the question. I think Mr. Plante knows this answer better than me. Did you want to start? Oh, I'll start. Thank you for your question. In fact, you've really put your finger on the problem in terms of the clients and the service providers. That's why the programs we have and the strategy we need have different means to achieve their objectives. The NIHP refunds the expenses of its clients, and it works really well in urban centers or semi-urban areas where people have access to dentists. Programs such as the Children's Oral Health Initiative are most often used in communities where services, there's no other offer of services. In urban centers, these programs can be good for school prevention and for helping families and for helping children to see specialists and dentists. So this is how we combine our programs, and this is what's important in our strategy. We have to combine the efforts of these programs to help people in remote areas. Sometimes we can use contract dentists rather than having independent service providers, and some regions we use contracts to reach communities. It's more efficient, it costs less, and it makes sure there's a service provider in a remote and local support. So we have very different service approaches depending on what region is involved and the geographic location of our clients. Earlier, my colleague was talking about our regional strategies. These regional access strategies take account of all these dynamics and helps us to serve our clients and bring service providers to these communities. That's where I'm heading. When we say bringing service providers in, we're talking about dentists or their assistants and the necessary equipment in. So the necessary equipment for a dentist, they don't just travel with a little bag or a suitcase. It's a little heavier than that. It must cost a lot of money. So what I'm trying to say is most of the expenses, do they go to the health care or does it go to the delivery of these services or the cost to bring the dentist to the community and bring in all the necessary equipment? So most of the budget, does it go to the logistics or mostly to the provision of services? Very good question. I can reassure you on that. Part of our expenses do go to medical transportation. But the figures you see in the AG's reports are specifically related to the services and the provided. For example, when we build nursing stations in remote communities, there's one room that is dedicated to dental health, and there's a chair there. And so this program finances local workers, and they establish lists of appointments, and people show up locally. But it's really useful. Oh, and one of the positive points of this program of the Children's Oral Health Initiative is the local support. They have professionals that make regular visits, and there's someone in the community that can make sure that customers are registered and they can show up and they receive follow-up care. So it's really important. So it takes a local dynamic and local setup. You mentioned in the report, Auditor General, that Indigenous peoples have 2 times as many dental issues as non-Indigenous peoples. Is it true across Canada? Are there Indigenous people who live in urban areas that experience the same problems? Do they have the same issues as non-Indigenous peoples? Is there a big difference between those who live in north or in urban centers? Thank you. We did not conduct a precise analysis on this issue. In paragraph 4.2, we state that oral health is more precarious and is related to factors such as geographical obstacles. So it is obvious that in some communities it's more difficult to provide services, particularly in remote regions. So that's a challenge. And I think that's another reason why it's important to have a national strategy to determine how to provide these services to the population. Perhaps I could ask a question to people who live with this daily, Mr. Tremblay. There's recent information. It's not difficult to obtain, but I can get back to you with a recent survey that was conducted on dental health. I think it was conducted in 2007. So then we can look at the regional differences and the divide between the north and the south and urban centers and non-urban. Thank you.
Please, you have 7 minutes.
Very good. Thank you, Chair, and thank you all for your attendance today. Again, it won't come as a surprise to anyone that when it comes to services for Indigenous peoples, Canada does an abysmal job, especially compared to our reputation in so many other areas. This report is not the worst I've seen. I've seen some nightmares come through here, but it's still not good. Still not good. My colleagues have already addressed some of the most obvious questions. I'd like to drill down just a little, Chair, if I might. Auditor General, at the beginning of, the beginning of the year, certainly near the beginning of the term, you presented us with the fact that you considered data collection, data analysis, accuracy of data to be a key component, and you were concerned and addressed our committee that it needed to change, and that after all these years, we're great at getting bunches of data, but using them effectively and analyzing them effectively and getting the best benefit hasn't been so good, my words. So I want to focus on that. And I notice in your report, I'm looking at page 10, 4.45, where you say, however, department officials informed us that the apparent decline in enrollment might reflect poor quality in data collection and recording. Very next page, your recommendation is that Health Canada should improve, we know that's switched now, but should improve its analysis of data. And even in, Deputy, your remarks, I found at least 3 occasions where you mentioned it. Page 4, you talked about data collection, analysis, and reporting. Page 5, you mentioned that your plan will ensure that data collected in the course of the delivery of services will be accurate and rich enough to contribute to overall improved management. And another one on page 6, where you talk again about the importance. In fact, we find that it's a focus of the action plan, which is a critical component of the work we do. And in there, referring to the recommendations coming from paragraph 4.47, the key interim milestones, one of them is you make a reference to the Data Improvement Strategy Working Group. And I'd like you to talk to me about that group. And is that new? Is it a result of the initiatives of the AG? Is it something you've always had? Can you just talk to me about that, please, before I go any further? What the Data Improvement Strategy Working Group.
Laurent?
Yeah, I can start and maybe Dr. Plante can complement. Thank you for the question. There is a number of programs and different ways to collect information. For example, the Children Oral Health Initiative depend on the work that is done in each of the 200 communities on day-to-day services to record the service provided, the oral health of the child, and measure progression in terms of the quality of the oral health. This requires calibration to make sure that the data collected in Northern Manitoba will be consistent to the data collected in Northern Quebec.
When did all this start?
And we have been doing that all the time to try to improve, but there is a challenge to get this data, to analyze it at the national level, and this is what the Auditor General revealed in the report, which is it's not something that is conclusive. So there's more work to be done there. Second, we have many programs. We need to be able to link this data together. So the working group is made of people from the various programs to try to harmonize the way they collect the data and they organize the data, provide the training, and also using external experts to advise us. So in the introduction remark, we talk a little bit about the expert group, which is independent. They gave us guidance about how we make this happen. So this working group is charged to implement these measures.
Thank you. Deputy or Auditor General, does every department have one of these? Or is this unique to you? A data improvement strategy working group. In other words, a group that is actually struck for the sole purpose of dealing with the issue of poor data management and analysis.
I cannot talk for all the departments. I'm not sure of this.
Okay,
but I think all departments have a data strategy for sure.
All right. Auditor General, do you know, sir?
No, I don't know whether all departments have it, and obviously we've seen issues in a number of departments around data quality. So I suspect it's not all departments, but I don't know that for sure.
Okay. So my other question is, and what I'd like is the actual from you, Deputy, and then AG, whether that meets what you think should be happening. But we don't talk a lot about internal audit committees, and yet I think they play a bigger role than we're acknowledging. And would they be responsible for the issue of data management, Deputy?
No, the audit committee, the internal audit committee, works with us and advises the Deputy Minister on the quality of the audit that we produce, on the risk management of our audits, which audits do we do, and they will advise us on the quality of those audits, on what we should identify as risks, where we should go, what we should address, but they will not necessarily be part of the working groups.
Okay. Because see, what surprises me is, and it happens over and over, is that the AG, and it's in here again, I can dig it out if you want, but there's analysis that said that the planning wasn't done. They weren't following up on these things, strategic analysis, and it seems to me that the in-house audit committee ought to be doing some of that. So what I'm asking is, if we've got an in-house audit committee and they're doing their job, how is it we can get through them and still have so many problems that the National Auditor General finds them?
Parliament has to do its job. The audit committee cannot do the job of the department, so we have to do it by ourselves. We have to do it also with our partners. We have to find ways that are efficient, that are also sustainable on the way to collect data and also to actually analyze those data. This is our responsibility. We recognize it. And as we said, we're developing a plans, and we hope that we will be able to...
No. But what I'm getting... Very quickly. Well, maybe I'll just give the Auditor General a chance to comment. I'll come back to this again. I'll get another round of questions. But that was a bit cursory for me. I'm looking for a little more, Deputy, in the next round. Auditor General?
I think there is a role for audit committees, internal audit committees, to play in this. As the Deputy said, obviously dealing with these issues and fixing these issues is the responsibility of the departments. But I think that there would be a role for audit committees to look, for example, at different audits that we've done. And as the question indicated, in a number of our audits, we have talked about the problems with data quality in departments. So I think audit committees should be aware of those types of systemic issues that we bring up, and they should ask the departments that they're involved in, how do we know whether the data in this department is being managed in a way that it is of sufficient quality so that this department doesn't end up with data quality issues showing up in an Auditor General's report. So it is definitely the responsibility of the department to fix the issues, but I think there is an oversight role and a challenge role for internal audit committees to make sure that departments are paying attention to these types of issues.
Thank you, Auditor General.
Thank you, Mr. Ferguson and Mr. Christofferson. We'll now move to Mr. Chen, please.
Thank you very much, Mr. Chair. Oral health is so important. We all know that. I know that. I recently had a feeling that went bad, and it was not good. It was painful, but we won't get into the details of that. I'm lucky. I have access to any number of dentists in Ottawa and Toronto. I have a good insurance plan, but we know, and it is especially important, that there are many communities and many individuals in this country who are disadvantaged, marginalized, and they do not have access to proper services. And That is why it's so important for us to ensure that Indigenous children, in particular, have proper oral health. It's no secret that the oral health of Inuit and First Nation children is especially poor, and I heard the Auditor General say very clearly in his remarks earlier that with respect to the work of the department, it did not focus on closing the gap. What we need to do is very much remember that there is a gap, and it is our responsibility to close that gap, because there are children that do not have access to these services, and oral health is so important because it is linked to general health outcomes. It is linked to their ability to receive a proper education. It is linked to their personal sense of well-being and confidence. When there is poor oral health, there is poor outcomes for children. In the Auditor General's report on page 3, paragraph 4.9, it states that $5.4 million was allocated by the federal government in 2014-15 for the Children's Oral Health Initiative. But in 2016, Health Canada found that only 238 out of 452 eligible communities received services. So of course, I'm going to go to the negative and say, why didn't 214 communities receive any services? Why was that the case?
We go with the resources that we have, with the funding that we receive under the budget 2017. We expect that we would increase by more than 100 the number of communities that actually have access to COHI. So that's something that actually would help in terms of health, on the oral health. But don't forget that all those communities still have access to the NIHB services. So if they want an access to dentists, if they need access to a oral health specialist, they do have that access. It's not communities that are not covered from any kind of oral health services. That's not necessarily the case. This is more for the community approach that we described before, where we help to actually promote, do some prevention works in terms of oral health in communities. And that's something we were doing with $5 million, as you mentioned, but with the increase of budget that we receive, we hope that we will be able to expand this, and we would expand it in terms of numbers of communities and potentially also in the age of the people who would have access to the service.
So you're saying that with the budget increases that were passed, there will be an increase in the number of communities
2017, yes.
And as well in the age range. Currently, what is the age range for
I
children?
think it's 0 to 7.
And what is the department looking at in terms of increasing the age range of children?
0 to 11.
0 to 11.
But it may vary from place to place, but it is something that we're looking at, yes.
Can you talk about the importance, because when we are dealing with Indigenous communities, it's very much important for us to ensure that the communities are involved in the delivery of service. There needs to be a sense of cultural appropriateness and ensuring that Indigenous ways of knowing are incorporated in the services that are provided to members of that community. Can you talk about the importance of that and how that thinking has been incorporated into your goal ultimately of ensuring that more children, more First Nations and Inuit children are provided these services?
Do you want to maybe elaborate a bit on COHI?
Yeah, I can. So first, the budget 2017 is an additional investment of $45 million over 5 years in this program. And we have, right after the announcement, engaged with First Nation and Inuit partners across the country to determine how this funding was to be allocated. This year, for the first time, we have increased the budget of all the 237 communities that were receiving the program because they had the same amount for a number of years. So this budget allowed to increase capacity of existing sites. And then we are starting to create new sites in new communities. So this, at the end of the year, we'll be probably at 140 new locations where this program is available. And we did that with the input of our partner in each and every region, First Nation Inuit partners. In the non-insured health benefit program, which is more a fee-for-service model, we are also paying attention and working with the Assembly of First Nation, for example, to make sure that the provider understand the client groups, are culturally sensitive. Fortunately, in both programs, we have providers that are Indigenous themselves, and that understand, but we have to partners with others to train and provide information. A lot of the workers that we have internally in the department are Indigenous already, so there's many fronts by which we will ensure cultural safety around this program. What I mentioned before, into another response, what is really important is also to find a way to have local staff tasked to manage these programs at the local level and make it work in their context, creating the trust with the parents and with the child that these services will be good for them. You know, I think we will all agree that going to the dentist is not your first choice in the day. So we need local worker to give comfort that this is good for them, it's useful, and it will help over time to prevent problem. We have to do it in partnership. We cannot do it from outside. And this is why these programs have to be grounded in the community. We need to stabilize which provider goes in the community to make sure they develop a relationship and continuity of services with the family and with the child. Very, very important.
Absolutely. So the Auditor General said that with respect to the $5 million investment in the Children's Oral Health Initiative, that indeed the department's data showed that less children were enrolled and less services were provided. So I think it's great that you are looking forward to the additional investment. You're looking to reach out to more communities. You're working with Indigenous communities to ensure that services are culturally relevant and that they are involved in the process. And as you say, you have providers that indeed are Indigenous themselves. However, why should I be convinced that with more money and with what you're doing, that you are going to have better outcomes? Because as the Auditor General pointed out today, less children, less services were provided with that $5 million investment.
Thank you. Unfortunately, we're going to have to get the answer a little later because we're way over. We'll go to Mr. Deltel.
Thank you so much, Mr. Chair. I just want to get back to the point that I addressed a few minutes ago about the difference between the Indigenous community near the downtown or near the urban center and those who are up north. And I thank, gentlemen, for your concrete plan and strategic approach. That's the word you used in your introduction remark. I think you shall focus on that difference and put emphasis, this is my observation, to put emphasis in the up north. Those people are far away from the dental necessities, and if there is a new approach to have, it should be concentrate or focus on this community, those communities. But this is my personal observation, and I'm sure that you will make good of that. J'aimerais continuer encore, Monsieur le Président, sur...
Chair, I would like to move to more general visions of dental care for First Nations. Mr. Tremblay, earlier you talked about asthma and other diseases. In terms of dental disease, you also have to talk about food and diet. My question is first for Mr. Ferguson. In your analysis, did you look at the overall picture as much as possible in terms of the dietary habits of Indigenous peoples and non-Indigenous people? Because as we all know, poor diet leads to poor teeth. Thank you. That's another indicator, such as geographic obstacles. We identified 5 of these factors, and a certain number of was limited access to affordable and nutritive food. So, nutritious food. So there are other obstacles, such as smoking rates, which are high, and education levels. So there are a lot of different factors that can have an impact on the health levels of these populations. Access to nutritious food is one of these factors, yes. Now, I'm wondering about a very sensitive question. If we want people to eat healthy, we want them to, but we can't force them to. My question is now for Mr. Tremblay. When there are containers that go from the north, that go from the south to the north, that contain food, do we do an analysis of what these containers enclose? No, not that I know of. In your opinion, should we do so? I'm just asking the question rather openly. I rather people, our political party likes to let people make their own choices, but at the same time, we should try to positively encourage them to have healthy lifestyle habits. So perhaps this is something we could look at or analyze or encourage. I think personally that prevention work is the best work to do, education and prevention. And then, as you know, in the department of Ms. Bennett, for northern communities, there are programs for nutrition in the north. So we like to encourage and make sure that these foods get to them, so to encourage good health. So that is a challenge, of course, as well as costs of nutritious foods. But in terms of deciding what should be in containers sent to communities, I don't know. Okay, good. No, I agree with you. The government isn't here to tell people what to do and to oblige them to do things, but we can encourage them to do so. It's just strengthening what we said earlier. We have to work with communities. We have to make them aware. It's a work we do on the community level. If they have access to traditional foods and indigenous foods that they've accessed for years, they're not as accessible today. Speaking of that, did you do an analysis of traditional indigenous foods in these communities? Is it positive or negative on dental health? I did not do the analysis. I don't think there is any. There are university researchers that have looked at this at the University of Montreal, among others. I think that could be something to think about to give First Nations more possibilities for maintaining, preserving, developing their traditional foods, and also increases their feeling of belonging. It's not up to us in the South to tell people what to do in the North. They're in a better position to know what's good or not for them. Yes, I agree.
Area, please. Mr. Area, you have 5 minutes. We're in the second round.
Thank you, Mr. Chair. Mr. Tremblay, I would like to continue the question that was asked by my colleague Sean. Auditor General report mentioned that with the $5 million initiative, that fewer children were enrolled and fewer services were provided compared to the previous years. Now, budget 2017 increased the amount available. But what's the point in increasing the amount when you can't use the existing money that was already provided?
You wanted to go with that?
Yeah. I think the Children Oral Health Initiative was introduced in 2005 with $5 million. We were in 2017-18 when the Office of the Auditor General made the audit, and this was the same budget. So over time, the capacity of the community to deliver the service, because this funding is going toward the communities mainly, with the same budget is limited. So somehow the hypothesis of increasing the resources is coming from the fact that 15 years at the same level is not...
Yeah, the budget was at the same level, but the data shows that fewer children were accessing it.
No, but that's the point. If you look at over 10 years, of course, the costs have increased, but not the budget. So one of the hypotheses, and that's why we're going to need to have more information about this, but it's also that if you give the same amount of money, you basically have, if you want to cut, because you don't follow necessarily a CPI.
So you don't know the reason why fewer children are accessing it, but you're happy with more budget?
Our understanding of this is actually that if you kept the budget as it was 10 years ago, it's difficult to get the same result that you had a few years ago.
Okay.
And we're quite confident that with this new amount of money that we will be able to reach out more communities.
Because of the budget you say is low, it was kept at the same level in 2005. Have you ever turned away a child who came for the services?
If we have been looking for, sorry?
If with the same budget, have you ever asked a child that you can't provide the services because there is no budget?
No, what we've been doing is to transfer the dollars to the communities, the same ones that were dealing with that were having these programs, and with the same amount of money, they were trying to reproduce and to do what they can. But the cost, for example, of hiring people to the therapist and so on increase over time. So we we
I
think
got a
that,
question for the
Yeah.
Auditor General. I know you looked at these two programs, but looking at this program in isolation, I don't know if it is of benefit to us. Why? Because this is just one program related to health. There are other health factors. For example, the increase in diabetes that is amongst the indigenous people, and there are things related to, say, foster care, and there are other issues like mental health services. Is it possible to look at the entire big picture that affects the children?
Well, certainly, as you say, there are many different factors that we can look at. When we do a particular audit, we have to scope it down to what we can do within a particular time frame. So that's why we picked this, and that's why we focused in on this, so that we could get a report on one subject. Certainly, all of those other subjects could be the subject of audits in the future.
And the same question to the Deputy Minister. Do you look at this program in isolation? How are you fitting that with the mental health services that you provide, or the increase in diabetes, or the issues with the foster care?
Yeah, our objective over long term is not to go by program with First Nation and Inuit and Métis communities. It's to go with a fiscal relationship where they would have their community plan and it will address holistically the different elements or different sectors and issues that they have, rather than actually going case by case. So to answer your question, it's something that we're working on. We end up with a lot of programs. Programs are not necessarily as flexible as they should be. And as you said, sometimes there's a bit just one part of the story, not necessarily giving you a full picture of the
I got
situation.
limited time. I'm sorry, apologize. On the dentist contractors, the contract dentists, I know there's an issue there. How do you think you're going to address that?
What do you mean?
On the dentists on contracts, I believe you have got difficulty in having enough number of them.
We've got almost 16 or 17,000 dentists across the country. The real difficulty is more with the therapists.
Okay.
Because there's some provinces where therapists are actually will not continue to work, and we were using in some regions, for example, Atlantic and Manitoba, where the COHI programs use a lot.
The reason I asked that was that Auditor General found in one of the two regions there were not enough contract dentists available to provide the services in the communities itself.
Thank you. All right. We'll now go back to Monsieur Deltel. Your time is up, Mr. Area. Mr. Deltel.
Merci à nouveau, Monsieur le Président. Continuons notre...
Thank you once again, Chair. So continuing on the topic of general services to First Nations, and based on the analysis that were conducted and the commitments you've made, in general, when we talk about health for First Nations, we know that there are a lot of challenges with regard to social services and consumption and dental health. Is dental health a priority in terms of health for First Nations? I think I'll ask the First Nations to talk about that. Their priorities are different, and across the country, we think that dental health is a priority, of course. When you look at the number of people who have access to our services, who want to have access to dentists, it shows that there's need there. People do want to have better dental health, but of course, health is a priority, but it includes several different factors. As you mentioned, mental health, diabetes, and other factors as well. I can't just really say that that's their number one priority. I would ask you to look at the plan that was presented by the Assembly of First Nations in 2017, and it includes a list of health priorities. In our partnership approach, their viewpoints are taken into consideration in terms of the actions we take. You'll see in this plan that there's a multi-sector approach for primary care, mental care, preventive care, and dental care as well. And those are the priorities that they identified, and they have a holistic approach that they propose. It's always delicate to try and judge the situation, and we're the last people who probably should do that. We wouldn't want to tell people what they should have to do. They should be deciding what they want to do. It's true for First Nations and elsewhere, and every sector. the people who are experiencing the problems should be providing their feedback. But it's not up to us in the South to tell people in the North what they should be doing, what's good for them. That's what we think, anyway. But my question, Mr. Tremblay, is for how do you, as a top official, and as administrator, and as a deputy minister, to the best of your knowledge and in the budget, dental health, there should be a priority in terms your role. Yes, in terms of basic health care, I think it's important not to have to make a choice. Basic health services should be provided to Indigenous peoples and to all Canadians. Access to health care is important, whether it's mental health, primary care, hospitals. For us, we don't seeing as making one service a priority over another's. It should be basic health care for all citizens. They should be accessible in an efficient manner and easily to all Canadians. I just want to make a general comment. The more we look at the issues of young people, the fewer problems there are later on down the road. So the more prevention there is, the more the information there is, the more access to quality care there is in terms of dental health and mental health and others, basic health care. It can prevent unfortunate accidents later on down the road, particularly what we see, unfortunately, in some sectors. There's figures that indicate that some people are more subject to facing tragic incidents. So we need a particular approach to health people and helping young people. So I'll end with that.
We'll now move back to Ms. Yip, please.
Okay. It was found that Indigenous services did not promptly inform clients and service providers about the changes it made to certain services. And I would like to know how they are going to improve the promptness of informing clients when there's service changes. Especially when you're dealing with kids, it's tough juggling schedules, and then, when you're relying on something as important as these appointments.
Yeah, and the difficulty with clients is just, let's say you're a client and I'm a client, or you're a client, for example, after your fillings. It's not something on a day-to-day basis you wake up and say, what exactly the new policy and what should I have access to, or what do I have access to? So we need to find a way to make sure that they know it and they have access to it, and especially when they need to know it. So it's hard because it's not something that people think on a daily basis. What is actually what is my access to dental care? So we're working with First Nation Inuit communities and organizations, trying to find a ways of actually the way to ensure that we actually kind of reach out to and communicate to our partners and to the clients. We're talking about a potential of 853,000 clients at the moment, dispersed across the country on and off reserve, so it's a vast population. For us, it means that we'll be working with communities, working with the premier health care centers that exist in the communities, with the health professionals, and also, of course, working potentially with social medias on a way to actually make sure that they have access to the most information perspective possible. We also have newsletters that inform people about what we're doing, and that's something that we're looking at to improve. And I don't know if Dr. Plant, you want to add something on this?
Yeah, we're looking at a strategy, also working with our partners so that they know better than we know how to get to the people that need the information. So we are looking into a plan in the next few months to do a better job about communicating. We already made an improvement. We have it now. The clients can subscribe on our website now to have all the newsletter for clients. The information on the program itself, they have the same information as a dentist. The issue with that information is sometimes it's very technical, so that's why we're trying to find new ways of explaining the services that they have the right to have, basically. So this is all work that's being done. We're working also with the Canadian Dental Association. Whenever we make changes now, they also publish sometimes on their website. Other associations also, like the Dentist Association of Canada, also the Dental Agents of Canada, they're helping us trying to spread the word throughout the providers, but also on the client side because they see the client in their offices also. So there's a lot of work to be done for sure.
Thank you.
Just before we go to the next round, because we do have another minute or two on your round, I would like to ask a question. I'm just looking at the Auditor General 4.44 when he says that the Health Canada's data for the school year ending in 14, 15, and 16 showed that the Children's Oral Health Initiative had not met its enrollment targets, but that it had met most of its targets for the delivery of preventative services. And then later on, I guess where I'm going is when you have general health care amongst First Nation or Inuit or on or off reserve, typically off reserve, we know that it's not simply a doctor that can deliver that type of health care. It can be a nurse, it can be a nurse practitioner, it can be just a whole large group of people that can deliver some health care. On dental, it's a little different. You have a dentist and a dental hygienist. I'm not sure if there's any other groups other than them two that can do typical dental work. However, the Auditor General in his report said that when it came to prevention, I understand there's things you can educate on the importance of, things like brushing and hygiene. But about 20% fewer fluoride applications in 2016 than 2014. And that kind of struck me. I mean, we know that fluoride applications, certainly in remote areas where it's not in their water supply, can help prevent cavities and certainly help with not with hygiene, but with with dental health or with the health. Why then would there be such a drastic drop in fluoride applications? 2 years after from 14 to 16.
Dr. Plante, do you want to try that one?
The COI program is a voluntary program, so the parents can enroll or not enroll their kids. But also, COI is only part of the big team, basically, because fluoride can be provided by provincial programs, can be provided by NIHB through private means.
So is that the case? Like, did it drop here because the province had increased?
We cannot say that. We can only.
So then, how do you take this data of a 20% drop in fluoride treatment and respond to it if you don't know that it's it might be covered by province, it might be covered by other groups?
That's why we need to look a little bit closer, like we said before, at the reason why we are seeing this happening. But it could be, like I said, we're just putting a hypothesis out there. It's we have to really look closely what is happening there. So with putting the data together, that's one of the reasons we'll have a better sense of where the clients are going also. The only data that we will not have is the data from the provincial government for sure, but at least throughout our programs, if we are able to put the data together, we'll have a better story for each client.
Thank you.
Individually.
Thank you. Mr. Nuttall. Oh, Mr. Christopherson.
All right. Thank you. I had indicated I'd be looking, Deputy, to you for a further answer, but you're in luck. The answers that the AG gave me what I wanted. I do hope you reflect on that answer. It wasn't very good. I do want to just say, hope springs eternal, and a lot of emphasis in the response from the government is placed in the new restructuring, that should allow the synergies of the various components to work together to give us more service delivery, whatever. I'll take anything. Like, just somebody show up and fix what's going on in terms of services for our First Nations people. So we shall see. But just remember, every time you make a promise that gets you out of today, that promise has to be accounted for someday down the road. I have two questions. My last, very brief, my last one will be on the macro data and how we're doing, Mr. Ferguson. But to the deputy, I want to read one paragraph, and I'd like your response, because this just blows me away. Page 6, 4.28, quote, "The department had known for many years that Inuit and First Nations people's oral health was poor and attempted to develop a strategic approach to improving it. We found that the department drafted strategic approaches to oral health in 2010 and 2015, but did not finalize them. The department committed to the implementation of an oral health strategy and action plan in 2015. In its report on plans and priorities, department officials developed regional plans for oral health service delivery. They also continued to discuss a strategic approach to oral health, and in 2016, the department hired a contractor to develop one. At the time of our audit, the department had not finalized a strategic approach." End quote. What the heck is going on with this? Why is it so difficult to come up with a strategic plan, and why promises and then failure to honor those promises, and all we have today is another promise? So give me some reason to believe, Deputy, that this time you folks are actually serious about keeping the promise as opposed to your track record.
First of all, I would say that there was regional plans. We were working on this. We knew that there was a poor health, oral health situations for First Nation in Inuit. We have programs that were developed with this. For this, we base our decisions on evidence base. We work with experts in developing those programs, and we put them in place. Now we're going to a more mature level in our programs where, yes, we will try to have finally a national approach where we can compare the data from between and among our programs as well as among regions, and try to make sure that we have the resource, we have the kind of demand that we need for the population that we deserve, that we serve.
All right, I hear you going forward, and again, it's more promises, but talk to me about the failure along the way. How can this be something so important and all these fits and starts and we're still not there? Like, this is about accountability. So it's not just what's going forward. We want to know what the heck happened in the past, and this is a disaster, and I haven't heard you give me one good reason why it happened, nor even acknowledge. So, Deputy, please.
We acknowledge that there are progress to be made. The national strategy is not necessarily everything that will fix everything here. As it was mentioned, those issues are broader than just a strategy at the national level on how we will collect the data among those programs. It's an important step, and we will take that step. That's the way we see it.
No, I don't like that answer at all. I got to tell you, I'm not consistent with the other answers. You're not. I'm sorry, but I don't get the feeling you're listening and addressing what we're dealing with. You want to talk about what you want to talk about, and we're insisting you talk about what we want to talk about. So I'll leave that. I don't have a lot of time. This round is very brief, but I'm sorry, that answer was not sufficient, Deputy, and it didn't address how the heck so many mistakes were made in the past, and dealing with why we should listen to this promise when you made promises before and you didn't keep them. Last question, macro. Auditor General, I had raised the issue of data. I raised the fact that you'd come to us with a report asking us to make it as much of a priority as we can. We've tried to do that. We could always do a better job, like everybody and everything. But are we making a difference, Auditor General? Are we starting to turn the corner at all, or do we need to ramp up our efforts because we're still not getting the message through? Can you give me your thoughts, sir?
I think in general, we still, when we're doing audits, we still see many problems with how departments are collecting and managing data. I think, though, the committee has been successful in starting to shed some light on this, and I think, departments are starting to take it more seriously, but I don't think it is yet showing up in our audits. In this particular case, in this particular audit, though, I would like to point out that there were some places where we saw that the department was doing some good things with data, and then some places where they needed to improve in data. The department has a lot of data about individual payments for individual services, okay? So when dentists are providing individual services and those services are being paid for through the department's program, they have a lot of data on that, and they have done a lot of analysis on that data to make sure that dentists are only claiming what they should and that people are only getting paid what they should. So they've been collecting a lot of data. That data is accurate, and they've been using that data to make sure payments are appropriate, okay? But they haven't been using the data sufficiently to manage the outcomes, right? To manage what can this data tell us about dental health outcomes and how can we use that data to improve that. Similarly, on something like the Children's Oral Health Initiative, they don't have the information about individual services because the department doesn't pay for each individual service. They pay for a hygienist perhaps to go into an area in some of these programs, and the hygienist gets paid, but not necessarily on an individual service, so they don't have as much information. And that's why when we talk about the Children's Oral Health Program and there appears to be some data quality issues, it's because they don't collect the same level of data. So they're doing a good job on some of it where they have the individual transactions. They need to use that information to get more insight out of that information, and then in some of these other places they just need to do a better job on collecting information in general.
Excellent. That's very helpful. Thank you so much, and thank you, Chair.
Christopherson. We'll now move to Mr. Tabara. Mr. Tabara, welcome to our committee.
Thank you.
Time is yours.
How many? 5 minutes?
Yeah, 5 minutes.
5 minutes?
Because you're new, we can give you up to 5.5, maybe 6. But
Thank you very much, Mr. Chair. Thank you for testifying here before us today. I actually had, when I was coming to Ottawa one time when I was traveling here, I was speaking to a nurse that was working in a Indigenous community up north, and she continues to work in Indigenous communities. And she was telling me about a lot of the services that they provide. And just for regular checkups, when individuals would come in, she would do regular checkups, but she would notice that their oral health was, to say the least, wasn't very good. I was just reading here, and I'm new to the committee, so sorry if I'm going to be asking repeated questions, but with the significant funds that was given in 2015, how will this take a national approach? Or sorry, not 2015, 2017, I apologize. How will this take a national approach?
It would help on the prevention side, which is the dimension that you were talking about, on how we will be able to reach out more communities, to work with them in terms of developing prevention and making sure that the good habits are there from the oral health perspective. So that's in part what it will do. And we will also build on this to develop the national strategy that, as we said, will be actually presented in the next few months.
But how do we do that this question is to anyone, how do we do that in the most remote communities that are, a lot of these communities face, very remote communities? How do we ensure that their oral health is...
We have to work with the communities. We have to have professionals that are going there, work with the communities and reach the families and the children, and actually work with them in terms of training, in terms of showing the benefits of a good oral health. Doing it with the partners for us is the key element, is the key point. It's the same thing even for the national strategy. We have to sit down with our partners, First Nation and Inuit. If we want to have targets over long term, it is targets that they need to, of course, embrace, like we will embrace them at the end. So it's different working groups that we have. It's different ways that we have actually to reach out and work with our partners. You
were talking about the patient journey, going to see the nurse, and I think this is a prime example. In the north, where there is a nurse, a patient will see the nurse. If there is a problem with the oral health, the nurse will do a couple of things. First, say, there is a dentist visiting the community in 2-3 weeks. I'm going to put you on the list. You should see, but this is more the prevention, convincing the patient to take care of that. If it's urgent, the nurse is going to arrange with our services to get the patient out. Sometimes there is pain and there is a need. If there is no dentist coming soon, the patient care is a priority. She's going to help her to arrange the patient to get out and get services from a dentist somewhere if it's emergency. If there is no visiting dentist, we sometimes organize flight out to see a dental providers. But it's why earlier today I was talking about these regional plans, because each community deserves a different action. Sometimes there is already dentists visiting communities. There is already dental therapists residing in communities. So in each case, we are trying to organize a service. But what matters is really that at all stage of the healthcare providing, whether it's the nurse doing prevention work or the dental therapist seeing the patient or the dentist outside of the community, we try to integrate all this work to make sure that this is patient-centric. We have a problem sometimes with data to be able to see the patient journey, but the staff and our partners have all the same information about what program can be leveraged to get the clients to the service provider as soon as possible when there is a need.
Okay. Yeah, okay. So just a follow-up question. So say if, to give you an example, say there was a dentist that was visiting the community, they performed surgery or they conducted something with the patient. Is there any follow-up? Maybe the dentist leaves again. You know, if you're extracting teeth, you have to check if it's healing properly. Is there any follow-up, or do nurses do that in that respect?
Yeah, this is part of the treatment and the process of serving the patient. There is a responsibility for the local nurse. There is a responsibility for the treating dentist. There is a responsibility for the dental therapist. What we have to work on is stabilization of the service provider community to make sure that the same dentist or the same dental therapist visits the community. When there is a disruption, then there might be difficulty to follow up with the clients. So investing into local workers as well, doing it with the community. So there is someone locally that is in charge of doing the follow-up, calling back the clients to make sure they show up when the dentist comes. If it's only 2 days a month, there is that window. So we need local workers to organize that and to be very efficient. Again, that's why we need plans in each region to organize the service in the most efficient way. Ultimately, however, if there is an urgent need, we get the patient out to see a dentist outside of the community for sure.
Thank you, Mr. Tabara. Now we will go to Mr. Nuttall, please. Mr. Nuttall, you have 5 minutes.
Thank you, Mr. Chair, and thank you for the presentation as well as the answering of questions today. The Auditor General highlighted both successes and needs for improvement surrounding data. And I just want to pick up on where Mr. Christopherson had been. So it sounds like the data is being used effectively when looking at the focus on dollars spent. Where it sounds like the data is not being used effectively is when it's supposed to focus on people and the actual person who's being helped, or taking the data from that person who has been helped and looking at a national statistics. So I guess my question is, at this point within your department, would you have data that you could pull that would say, you know, we're seeing this many issues in relation to oral health at this age with our young people on First Nations or even in the city?
We have a lot of data in terms of access to the service and what kind of surgery and what kind of service they receive. It's there. The issue is going to level 2, if you want, as you said, is to use that data to actually kind of try to prevent and look at what are the trends and what are the kind of services we should offer in the future, and where do we see progress and where do we see gaps. But we have actually a lot of that data.
So the funding that's put into this program, is that funding the analyzing of this data as well, or would there be separate individuals who do that work?
It is something that we're doing in the department.
Within the department, so you have direct control over that.
For the non-insured health benefit, we have the information. Yes.
So you would be able to then turn this information around pretty quickly.
Oh.
Yeah, and actually we are using the data we have to look at trends, the type of utilization, prevention versus treatment. So we do all this. What we cannot do, and I think our partners from the OAG are driving us, is to say, but you need to tell us if these services, whether they're, because they are evidence-based, how much you're improving the overall oral health, and that data doesn't tell us this. So we need more. We need to bring other data with this one to be able to say overall, you have scaling, exam that are done fluoridation, but is the oral health is improving overall. So we know that the service we are funded and supporting are increasing, the demand, the utilization, which is all good indicators. But at the end, all this is leading to a better health outcome, oral health outcome. We need a population level survey, for example, to help us on that front, and we are working on this as well.
So we've got a lot of information on that.
But at the same time, the access is not increasing, right? And just let me finish this thought. So, if the data's there, and the funding is there, now you may ask for more funding, but the funding's there, but the access is actually going down. To me, that's a management issue. And the reason I call it a management issue is this, is we have the data to use to determine the path in which we need to go in order to attain results we're looking for. We have the funding in place as well. Even if the funding remains the same and it's not increasing, and you're right, the CPI, all of these things are contributing factors. The idea would be that we're finding efficiencies at the same time in every department in this government, not just yours. So if we're finding efficiencies, CPI, funding remains the same, but access is going down, plus we have data that we're not using. That's straight up a management issue. And that's something that I would like to see in the future. Once we go through this report as a committee, this is something I want to see a report back on, because if that data is truly there, it should take not very long to be able to provide examples to this committee as to what changes are going to be taking place. In fact, I can tell you, because we happen to be in politics and data is incredibly important to us. If I go to a group with zero information and say, I need a poll on these 10 subjects in these cities, I need you to bring back the information to me, we can analyze it, turn it around from front to back in 2 to 3 weeks. If you have the data already, I assume you should be able to do a similar thing.
Maybe a specific points on this. We've got significant level of data on the access to non-insured health benefit, which means going to the dentist and getting a surgery, for example. That individual access to the system, we have a lot of information. The areas where we've seen a decline and that we have to better explain in the future is on prevention. And this program, as it was mentioned, was the $5 million per year. It's not our major programs. It's actually the small programs in comparison with the rest. That's where we need to have more information. And as it was mentioned by the Auditor General, we don't necessarily have the same relationship with each individuals who participate in those events. So that's the part that we need to actually work on.
I think Mr. Nuttall's frustration on this, without putting words in our Auditor General's mouth, but quoting him, when he tabled these reports in the House of Commons, he said, and not just about this department, but about other departments in government, he said, too many federal government programs do not seem to measure success in terms of how they affect Canadians. So what Mr. Nuttall has said is, we do the data analysis, we pinpoint the money and where it's going and the issues and all those, but really when it boils right down to the effect on Canadians, that's where we have to take data and improve it on the people side. All right, Monsieur Massé, I think you may have the final say today. Go ahead.
Merci.
You have 5 minutes.
Monsieur Tremblay, Monsieur Perron.
Thank you, Mr. Tremblay, Mr. Perron. You have many years of experience at the department of this organization. So you've consulted for several years First Nations communities. In your opinion, with the expertise and experience you have, and given the fact that dental health of First Nations doesn't seem to be improving at the pace that we would like, there are still serious challenges to be resolved. We wouldn't be here today if there were no issues. So there are still challenges that remain, either administrative or in terms of data collection or administrative issues. So what I want to know is, if you had all the means that were available, what would be the 3 priorities that you would like to deal with? What are the 3 factors that you, or 3 things that you would like to implement to be able in coming years to solve this situation that is very important for First Nations? In terms of dental health, yes. Obviously, the question about more information and in terms of the results as well. That we need surveys to get direct information on what the impacts of what our programs are. That's our main concern. To be able to get this type of information, what that mean? It means we're working on it right now with people in the Public Health Agency, with Stats Canada, with the First Nations, with Inuit people. As I said, there's a study that will coming out in 2022 on health throughout Canada. And our objective is to develop an aspect of it for First Nations. And we're going to do this in partnership with First Nations to be able to measure the results of our programs. And we also want to see what actions we've taken versus the results that are obtained. So for us, this is clearly an important factor, and it's an essential one. First. Second, I would like to continue work in partnership with Indigenous peoples. I don't want to impose anything on them, so it has to come from them. We have to do it in partnership with them, and it has to be done by Indigenous authorities as well in the long term. The third thing, sorry, Mr. Tremblay, what do First Nations and Inuit organizations tell you in terms of dental health? Do they give you feedback or recommendations? What are the main things they tell you? I'll ask my colleague to answer your questions. They're the one who does the consultations. So we have to serve our customers with people who understand the cultural specificities. We also have to control the services. The approach isn't the same in the Quebec region, for example, in the north of Quebec. It's also not the same in the north of Ontario as it is in Toronto. So Indigenous peoples want to control these programs. They want to organize them and manage them to be adapted to their context. We have a regional strategy, but we need these services to be managed by the communities themselves. In BC, we don't have statistics because there was a regional health organization that ran this program. But we want to look at all health services for First Nations in BC rather than at the federal level. But what we did, we modified, not dramatically, but we marginally modified the services to make them better and more adapted to their situation in BC, and also more adapted to various sub-regions in BC. So we have to look at this question in depth to transfer federal responsibility for administration of these programs to people who are closer to the ground so they can organize them in a more efficient way. This is interesting. If I have enough time, Chair, how does this work? So there's an agreement that was developed between the department and the BC government? No, we did it with Indigenous peoples. It was negotiated over several years. So this is a model that we look at. Funds were given during the last budget to encourage them to continue this health initiative. For us, we have to look at, make sure that the services are provided to Indigenous peoples. We also have to make sure they're developed to meet their needs. In your planning, strategic national planning, something that we want to see. We hope we'll be able to do it rather quickly so we can look at the results and your game plan. Well, in this planning, will this model be used in other jurisdictions where you want to implement it? We are going beyond this, and that's my third point I wanted to make. It's a holistic approach. We can't do it piecemeal. We need to give people the means to deliver these services. So this approach for us goes beyond dental health services. It goes, or even general health services or social services. as I've said, we've made negotiations in Northern Ontario, we've done negotiations there, and in BC. We could also talk about education in the Atlantic and autonomy there. So it's this kind of approach that we're looking at. We don't just have one way of doing things. We can't impose our way, but one of the department's objectives is to move to a more holistic approach as quickly as possible throughout the country. Yes. If I may, Mr. Chair, another question for Mr. Ferguson. We talked about strategic planning and data collection and data analyses and administrative processes. And there are projects that seem to be providing results. Is there something we missed when we looked at your report that you would like to bring to our attention? Did we miss anything that you would like to point out? We have a few minutes left. I think, in general, we looked at the key points. First, to understand the impact of these services and to understand whether it's possible to reduce the gap that currently exists. Perhaps there's one topic that we really didn't get to, is to understand all the obstacles that there are. We talked about food and geography, but there's challenges in terms of facilities and housing for Indigenous peoples or peoples who do this work. There's also people who have to travel to these remote communities and all these type of obstacles that are in place because these communities are remote. Is the equipment, does it exist in the communities? Is there housing in these communities? So that's another aspect of the issue that we did not discuss today. Thank you, Auditor General. I really appreciate your answer, and your reports are very important because I spent several years as a public servant, and sometimes we focus on months and years of delivering service programs, and sometimes we look at our service provision in a limited way. So this gives us a bit of hindsight. It allows us to take a step back and to see whether we should refocus how we provide our services. So this is good. So I just wanted to point this out once again. You're doing a remarkable job, you and your team, and to help parliamentarians as well as public services, the public servants who offer services to Canadians and First Nations and Inuit. So thank you very much.
Mr. Massé, and thank you to all our guests that have been here today. Typically at the end of a meeting, I remind those who have attended that the Auditor General issued his report on this. I think he had 5 or 6 recommendations. We also will be issuing a report on this study today. And as you leave here, you may contemplate some of the questions that were given to you, and if you're like me, you may be on your way home and you might say, you know, I could have added this to the answer, or I should have said this. If that should happen, we would encourage you to please to submit any further information that you would have to our clerks or to our analysts, to our committee, and that might be of benefit to us as we do try to build a report around this. We wish you all the best in the strategy that you're building, and also as you deliver for our Inuit and First Nations people. And I thank you, committee, for your good questions today, and Auditor General always for a job well done on the audit. So we are now adjourned.